Welcome to a celebration of 20 years of innovation. ESCRS this year represents 20 years since we have worked together to bring to market the MST Micro-Instrumentation, microforceps and scissor.
20 years ago, I was in Munich. I had a bunch of ideas. I met with Larry Lax, who was the vice president at the time. Now we have all these micro instruments that are doing all this. Back then, 20 years ago, we didn't have this stuff. And so MST took a chance on me, to come together. MST's become, the company in managing these complicated, difficult cases that we need the best instrumentation in our hands to work. I've loved this relationship. You guys have always been close to physicians, work and try to build the best products.
Cheers to you, cheers to a great partnership over the last 20 years, and here's to an additional 20 years of working together and 20 years more of innovation. So prost, everyone.
Our work is to try to simplify complex cases, to make them simple. That if we can do those steps really well with the right tools and the right thinking, that we can solve these big complicated problems. And that's kind of what surgery is about. When I started my career, I was doing difficult cases. People didn't want to do these cases. Why do like a 2-hour case when I can do 10 phacos? But these are the cases I think really patients need our help for. As I met with the team, I said, maybe we need to develop some instruments to be able to manipulate tissue in the eye, front of the eye. Micrograspers to grasp tissue and do work. And I thought, we tie sutures outside the eye, but we don't have good ways to tie sutures in the eye. And I like to suture a lot, using the right instruments to be able to grasp tissue, manipulate tissue, hold tissue to small incisions. And our goal is not just to improve a patient's vision here, but our goal is really to improve the patient's, quality of life, their self-esteem. This is an example of what my fellows have called Ike Ahmed, where we use a micro tire, suture, pass the suture in the eye, bring it outside, tie the suture and then slide it inside. A fairly straightforward technique, but much simplified than some of the complex iris suturing. When we're trying to suture iris tissue, this tissue is very delicate. And we really sometimes only have 1 or 2 chances to do it right without creating holes and trauma to it. But with the control, passing needles, passing the sutures without tension, I think can only be done with the right instruments. And I did not have that 20 years ago. And you can see that, remember what the case looked like before. We now have a more normal looking eye. We've addressed photophobia and glare and the patient's vision. But more importantly, these patients are so grateful for our work. Our work is left on a patient for their lifetime. And there's no better example than these cases with trauma, with iris abnormalities. MST, I don't think, is in the business of just doing routine cataract surgery, 5 minutes phacos, and that's it. We can do that. You can make a lot of money doing that. But is that really our purpose, being in medicine and healthcare? Our purpose is to help people who have the greatest need. And I think the ability to collaborate, these are sometimes 1.5-hour cases. My butt hurts after sitting down doing all these cases. My back is aching a bit. But man, you walk out of that, you see the patients and they look in the mirror after the surgery and the value we have is amazing. And I couldn't do it again, honestly, without the partnership with industry, partnership with engineering. One of my most favorite techniques, which is probably one of the most challenging techniques in ophthalmology, is the pupil cerclage. I make sure my fellows, all learn how to do this. This is using both hands, using multiple incisions, going back and forth. We're using a micro instrument here, micrograsper here to grab tissue, bring it to the needle, using different hand grips. My left hand is using the needle. So this really pushes to the limit. We've passed the suture across one quadrant of the iris. I now switch hands and we continue along. This is again, micro tying, suturing by looping it outside the eye and bringing it inside the eye. Sliding knot technique allows us to do this. We can titrate the tension to exactly the size we want. That's how it looked like after. This is before. This patient with a multifocal lens, unhappy with glare and halos, and has an open capsule. My approach is to grab the capsule under the anterior capsule, lift up the anterior capsule off of the IOL, place a Sinsky hook so we get some space, inject it with the OVD, and then sweep manually. Ability to hold the lens. You see there was a bit of a challenge with this haptic. It was pretty socked in there. So we're going to cut the haptic off using the IOL cutters from MST and a micrograsper to leave the haptic in there. Again, minimal tension on the capsule, very careful movements. We brought the IOL up. I like a bimanual cutting approach. I feel it's very controlled. These are the 19 gauge, heavy duty Iowa cutters, the best cutters that I've seen that allow us to cut any lens. And then now I just coat the vitreous face. There's no vitreous forward. We'll remove the remaining haptic now by more dissection carefully. And now we can place an IOL in the bag. Now the problem is that it's a toric lens. I put it in the eye, I rotate the lens, and what happens is the posterior capsule gets expanded. So I use a handcuff technique. I won't say where I learned it, but I've only been arrested once. And now I put a 10 nylon suture around the haptic, so now I can manipulate the lens, and once I'm happy with it, I can then cut the suture and then open the haptic. If I don't do this, then the haptic is open and I have to rotate it, and then it potentially drags on the capsule. I came up with this idea during this case. Literally, I thought, you know what? I've had too many challenges with these cases with open capsules and zonule cases, and I have to hold my breath. Is the capsule going to open up more? Well, now I have the haptics in position. I can carefully place the IOL there, and the capsule opening has not enlarged. It's the same size as it was before I started. And so, although many surgeons will say there's no way you can put an IOL back in the bag when you have an open capsule, I say, you know what? I think we can. Yes, we can do that, but I could not have done it without the instrumentation. MST's done a lot of nice work with developing kits to do this, make our job easier. But I mean, this of course would not be able to be done without the assistance of micro instruments like micro-tying, for example, to help to capture the haptic within the 30 gauge thin-walled needle. We often talk about technology, and sometimes we forget that some of the basic instruments in our OR are our most important. We talk about fancy, $500,000 technologies that are nice, but our most important and our most basic instrumentation to do these cases are what we use every day. Thank you so much for being here. It's been amazing, and for hearing the story. Thank you so much.